This week on the BackTable podcast.
There's some complex aneurysms. Sometimes they're really wide neck, and you don't want to get a lot of coils close to the parent vessel because that increases the risk of clot getting in there. So we want to, a lot of times we'll just temporize, like you said. We'll coil it really well. The rupture site, we feel it's secured. And then before they discharge, usually we'll put in a flow diverter. After everything's cooled off, they're out of the vasospasm window, and then we'll bring them back before they go home and get them queued up.
Hello, everyone, and welcome to BackTable, your source for all things endovascular and more. You can find all previous episodes of our podcast on any platform like Spotify or even our website, backtable.com. You can follow us on Twitter, Instagram, or LinkedIn, and keep up with the latest updates and give us feedback through comments.
First, a quick word from our sponsors. For those physicians treating wide-necked bifurcation brain aneurysms, the Webb intrasaccular device has been proven and widely utilized solution for many years. Recently, Webcast and Webcast 2 were published confirming safety and efficacy at 5-year follow-ups. Over the 5 years of the study, the Webb device demonstrated long-term stability and durability, as well as an adequate aneurysm occlusion rate of 77.9% and 0% Webb-related mortality or morbidity. For more information on the Webb device and the recent clinical data, reach out to your MicroVention sales representative. A decade ago, RapidAI harnessed AI to revolutionize stroke care. Now they are bringing that same innovation to aneurysm and pulmonary embolism. This AI-powered, clinically driven workflow platform enables care teams to accelerate triage and treatment decisions and improve operational efficiency to achieve better patient outcomes. RapidAI, where AI meets patient care. Now, back to the show.
I'm Sabeen as your host today, and we have Dr. Aaron Bress, a neuro-IR from Salt Lake City, Utah. Welcome, Aaron.
Thank you. Thank you for having me, Sabeen.
Absolutely. Thanks for coming on. We're definitely looking forward to expand our neuro interventions on BackTable. And one thing, we've talked a lot about ischemic stroke and things like that in the past, but looking forward to talking about cerebral aneurysms and hemorrhagic stroke. It's a heavy topic, but we'll go over it today.
All right, let's do it. I'm ready to jump in.
Let's do it. Before we get into that, though, let's talk about you, your practice, your journey into neuro-IR.
Yeah. So, I was born in Orlando, Florida, kind of a humble, lower middle class. My dad was a mailman. My mom, she kind of worked a 9-to-5, for AT&T initially, and then went into kind of the banking industry. So I worked hard, went to college at Emory University, med school in Kansas City, got my DO degree. That was pretty cool. And then, I did my radiology residency at University of Kentucky, which was awesome because that was resident driven. So the residents did everything. We took the call, we did night call, we were by ourselves. So I came out of that training man, I can be an attending day one. You know what I mean?
Totally. It's so funny how different residencies can be different, right? But resident driven really makes you prepared.
It does. Totally. And then I guess it was the feeling of sitting in a chair every day, all the time. I was like, man, I miss the clinical stuff.
Yeah.
And I gravitated towards neuro. It was before stroke was even a thing. It was the Mercy device was out. And I was like, man, this was kind of cool. And so I just went for it, man. I just went head first. So I did my fellowship training at the University of Pennsylvania.
Mm-hmm.
And that was an awesome training because I had both the neurosurgical attendings and the neuroradiology attendings. And so I had the best of both worlds. So I had the spine interventions as well as the endovascular, as well as the clinical from the neurosurgery and stuff. And so it was just an awesome experience.
When you made that decision, you wanted to be more hands-on and clinical. What made you decide neuro over body, when you had that choice coming out of residency?
I think at the University of Kentucky at the time, they weren't doing much vascular. It was a lot of more CT driven, more kind of drains and biopsies. And I was like, man, I like it, but it's not something I want to do forever.
Did you get good neuro exposure in Kentucky then?
We did. We had one neuroradiologist and one neurosurgeon, and they both were very welcoming. And maybe that was it too. They really taught well, and it was awesome.
Yeah, totally. And now your practice you cover multiple hospitals in Salt Lake, correct?
We do, yeah. Yep.
Is your practice all neuro IR? Are you mixed with interventional neurology, or is it a radiology practice? How is it broken down?
Yeah, so it's 3 neuroradiologists. It's 1 IR and IR. He had training in both.
Okay.
And then it's 1 endovascular surgeon. So it's a good mix.
Yeah, that's a good mix. And then are you with other diagnostic radiologists then, or those 4 is your group that you cover?
So that's like the NIR piece, but like my job is also like, so I have a whole clinical practice in NIR. Like we have like 4 nurse practitioners. We have a whole clinical outpatient thing going on. And in fact, one thing that's really interesting about our practice is that during COVID, we have now primarily virtual clinic visits.
Sure.
Because, like in the IR space, most of our clinical decisions are based on imaging.
Yeah.
And so we don't have to have patients come in and come out. Like if they want to come to our clinic, they do, but that's a rare exception. So the vast majority of our clinics are very similar to this. It's like a video or like a phone call or whatever. Most of it's kind of like on an app, and that's our interaction, and it works awesome.
Yeah, that's probably increased your efficiency like crazy then.
It saves so much time. Patients love it. And I think other people should incorporate it if they haven't yet.
I know. Our practice, we've incorporated a little bit of telehealth, but we still have long strides to go that we could do something like you're doing in your practice. Let's talk about cerebral aneurysms. That's our topic today. I think most of our listeners, if not all, probably know what an aneurysm is in the brain. But what I wanted to do was kind of divide this talk into ruptured and unruptured aneurysms.
Sure.
And we'll start off with ruptured. What % of people who have a ruptured aneurysm actually make it to the hospital to get treated?
So about 2/3 do. So, when we're in the field, they say about 1/3 or 30%-ish doesn't even make it to the hospital. And so then we get about 2/3 into the hospital. And then out of that pie, about 1/3 is completely normal, no problems.
Mm-hmm.
And then the rest will have some sort of neurologic deficit.
Got it. Guys, so kind of like a rule of thirds almost.
Thirds, yeah. That's what I try to keep it simple.
Yeah, I like that too. That's my style too. Hemorrhagic stroke, we know the diagnosis is usually made after they get scanned, CT, CTA. Do you use any scoring scales in your practice when you see these patients?
We don't. I mean, I know that the critical care doctors do. They grade like how big the subarachnoid hemorrhage is, and it kind of guides them should they get an EVD or not. But us as interventionalists, not too much.
Speaking of EVD though, like how, I know sometimes in our practice, we have a little bit of a rate limiting step when the patient needs an EVD prior to treatment. Do you do anyone with intraventricular hemorrhage, or do you have like a particular degree of hydrocephalus that you're like, okay, I'm going to do an EVD now versus wait till after treatment, or how does that work for you?
The vast majority is clinical. We have great neurocritical care doctors that get to the patient before we do. And so they really evaluate and they kind of pull the trigger on that. Sometimes if the patient comes up to us and they don't have an EVD, they're looking a little lethargic. It's like, whoa, let's talk to neurosurgery about this before we start. But if they look neurologically intact, we'll go ahead with the procedure.
How acutely do you have to treat it? I mean, if a rupture comes in at 1 a.m., do you call in the team and treat it at 1 a.m., or can you wait for a little bit?
Yeah, so we generally wait. I mean, it would be an extenuating circumstance. You always have that one case that you have to go in right now and do it. But for a general rule of thumb, like we'll wait till the morning and get them on, usually first case, and it's fine. I mean, I think there's even literature out there that they've done population studies and things and shown that, you can wait. You don't have to like rush in.
Exactly. Yeah, I was surprised by that because kind of my I trained in body, and when I thought, rupture aneurysm, you got to be right there, right then. But it's kind of nice. You can wait till the next morning. So frequently, since my group is combined neuro and body, I'll get a call overnight about a ruptured aneurysm, work it up and set it up for my neuro partners. So that was kind of a surprise to me that probably not many of our listeners know unless they're treating these. What other information, you get a call, patient has subarachnoid hemorrhage, a confirmed aneurysm on CTA. What other information pieces that you're looking for when you're getting that call from ER, ICU?
Yeah, the big thing is let's start basic. After they get the CTA, we'd love to have a CTA because it lets us know, like, localizes one, is there an aneurysm? Is there anything to treat? And then where it is. So we don't have to do a 4-vessel angiogram, So that's why I think getting a CTA before they come upstairs is a great thing. Another thing that we care about is parenchymal hemorrhage. If there's a lot of mass effect or things like that, we definitely want to talk to neurosurgery. Thankfully, we have a neurosurgeon in the team anyways, and we have an awesome neurosurgery group in the hospital. But yeah, just definitely in that situation, we definitely want to get them on board, kind of get their opinion, kind of get things going in that direction.
For the multiple hospitals that you cover, do you cover aneurysm treatment, hemorrhagic stroke at each one, or is it more of like a spoke and hub model where they'll come to a main center of yours?
Yeah, so basically all the hospitals that are in our system for hemorrhagic come to our place. We're like the main center in Salt Lake City, not the academic one, but
yeah,
it's a huge center. And man, I put it out there with the top 10 places in the country. We're a great place.
That's awesome. I'm sure it's super busy.
It's busy and it's fun. And yeah, it's great.
Since you have that busy and that volume, do you use any software? Like, we use in my practice where we can, view images at home really easily, talk to each other. Do you use stuff like that in your practice yet? There's Viz, there's Rapid.
Rapid. That's the one we use.
Yeah. It's nice, right? It's just nice having those.
It's great.
It's easy, especially like when I want to talk to my partners and be like, okay, like here, check this out. Okay. So that's kind of a brief touch on ruptured aneurysms. Before we talk about treatment of these, why don't we go kind of the other side and unruptured aneurysms? Now, do you use any scoring scale to figure out, you see a patient, some age and size? Is there anything that goes to your mind, whether it's subjectively or objectively, to talk to the patient about treatment?
Yeah, so this is like the magic. If someone had the XYZ of what and how to pull the trigger on when to treat endovascularly, I think every place has a little nuance to it. Our place is we've kind of settled like, if it's 4 millimeters or greater, we'll treat it. But, some patients, when they hear they have a brain aneurysm, whether it's 2 millimeters or 3 millimeters, depending on location and things like that, the patient just can't live with it. You know what I mean? Some can't. Some are like, oh, whatever, just do your yearly follow-up or whatever, and it's fine. But some patients, they mentally need to get it treated. And I think there's a lot of technology out there now that with flow diversion and stuff that if it's in the right spot, we can do it relatively safely as long as we talk to the patient about the risks. You got to let the patient know that this is basically kind of a brain surgery, so there are real risks to this. This isn't a little biopsy or something.
Yeah. I mean, I have to say that a treatment of an unruptured aneurysm, elective treatment in a young patient, I have to say that's probably the most nerve-wracking procedure in all of endovascular therapy. And I am fortunate enough to be exposed to a lot of endo techniques we cover in my hospital, vascular, neuro, this and that. But the most scariest thing that you can treat is a 40-year-old with a 6 millimeter PCOM aneurysm. Like, I don't know, that is so nerve-wracking. When did you feel comfortable doing that? How long does it take? What are some tips for people who are going through training right now?
Yeah, so I think that's where the neurosurgeons really have the mindset advantage. Like they come in and they're used to that. They're in the OR. They have complications all the time. M&M. Radiologists, by nature, anything complication, like we're like freaking out.
True. You're right. Yeah.
So there is a learning curve. You're absolutely right. For like me, it took a few years to kind of accept that you're going to have complications. It's part of the business. We don't like it. I hate it. It's the worst part of the business, but it happens. And you have to get into the mindset that, look, we're doing the best we can for these patients. We're trying all we can. Most of our cases elective like this are double scrubbed. We do them with 2 people. And, things happen. And we try to talk to patients beforehand that these things can happen. Although unlikely, it's unlikely. But, that's where the clinical aspect is for us. That's why we have clinic. That's why we talk to our patients. That's why we develop rapport and relationships. And that's where that kind of thing comes really into play.
Totally. I mean, what is your conversation with these patients? Say you have this, pretty young patient and you're going to do an elective repair treatment. What do you tell them to consent them or whatnot for the procedure?
Yeah, so I basically tell them the truth. That's the best way to go. And for us, I kind of use like our data. We probably have about a 2%, maybe a little less, of intraprocedural complication where it would rupture or significant stroke. So I let the patient know that's a possibility. And, a lot of times they ask like, well, what's stroke? So you tell them like, well, it could be a little numbness and tingling that goes away. People can become blind or die from strokes, but the likelihood of like a severe disabling stroke is pretty unlikely. So the odds are in their favor, but nothing's ever zero.
Totally. And like you said, it's all about the rapport you develop with the patient, their family. But like I said, I think it tops the list as far as the most nerve-wracking procedure in all of endovascular therapy is doing an elective aneurysm.
No, you nailed it. You nailed it because our young partner, he just joined the practice. He went into IR. He practiced body IR for a couple years, and then he went back to do his neuro IR training. And he said, "Man, this is a totally different level. The stress level, the mental, the mindset, the techniques."
Exactly. The patience level, like putting in and I'm for, I get to do it because I get to do it with my partners as an assist, but putting in that coil, if you're coiling the aneurysm, it's the slow, just patience, like, whereas, in the other parts of the body, we're just like, more or less, we're just shoving in a wire and putting it back. Like, there's a lot more room for mistakes, you can say, but the brain it does not give you much room, no room, So you have a neurosurgeon that you guys work with. How do you determine whether, and now this is for ruptured or unruptured aneurysms, how do you do that decision tree between a surgical treatment versus endo?
Yeah, a lot of it's, we have a good relationship with surgery. So generally, like if we can feel we can treat it, we go ahead and do it. And we're not cowboys. We really aren't. I think that's a superpower of our program is that we have an awesome relationship with the neurosurgeons. Our endovascular neurosurgeon, Dr. Yoon, we love him. We think he's super talented and we show him cases. He shows us cases. We're super collaborative. I think that mindset, that abundance mindset of just like,
yeah, collaboration.
Collaborate, exactly. And that really helps. I think at the end of the day, we're trying to serve patients and they get, and we get awesome outcomes most of the time.
That's great. So with the variety of devices that are out, how much would you say, how many aneurysms are going for open repair, clipping versus endovascular repair compared to, 5 years ago, maybe?
We don't have the numbers exactly. I would probably lean 80-20, the Pareto rule. That's always a good thing. So I think 80% are probably endovascular and 20% are clip. Probably if you look at at least our thing for our data for outpatient elective or ruptured, it's probably in that ballpark.
Yeah, I would say, I saw a big change over the last 5-7 years as far as the clipping and then just with all the devices, flow diverters and everything really has pushed things towards the endo route, which is great to be able, but definitely there are some aneurysms that are better served with clipping and from a skilled neurosurgeon. We'll briefly talk about, we won't go into the details. This will be for another talk for sure, but there's different devices and techniques that we can use now for treatment. Of course, there's coiling. Coiling technology has gone pretty far. What makes neuro coils better than body coils? Because they're like double, triple the price.
They are, the technology in them, the way they can form inside the aneurysm now, the way they can sit inside the aneurysm, the softness, and then just, some body coils, they stretch. It's very rare to have a neuro coil stretch on you. It takes an act of God to do that. Have I done it? I've done it. I feel like I've done almost every complication and then I do something else. You know what I mean?
It's always learning.
Exactly. But I'd say that's a big thing. The softness, the way it conforms, and it doesn't really stretch like some body coils can.
Sure. And then, what exactly is balloon-assisted coiling or stent-assisted coiling?
Yeah. So balloon-assisted coiling is where we use a really like a super compliant balloon. Those kind of generally lean. We do those more in the ruptured cases if we don't want to put a stent. And so you basically, it's hard to do it on just voice only. It's kind of a show is better, but we inflate the little microcatheter balloon right at the neck while we jail another microcatheter in the sac of the aneurysm. So basically it's kind of like a temporary stent. It acts as a scaffold while we put in the coils. And then, you can only keep it up. You don't want to go over 10 minutes. Okay. So generally some people do every coil. Some people try to get 1 or 2, maybe 3 at most coils and then bring it down. So you're constantly playing this game of up and down with the balloon.
Speaking of like keeping the balloon up and also maybe in a stent-assisted coiling, when would it be safe? This is a technical question, but do you start heparinizing the patient at any point, like when the dome of the aneurysm is protected at all, or are you avoid heparinizing a patient in the setting of a ruptured aneurysm?
Yeah, so we are, I think, a little more aggressive than definitely in my training. We're leaning, at least in my practice, I don't know about everybody else in our group, but I'm getting more comfortable with doing stent-assisted coiling during a ruptured.
Okay.
I get a much better pack. And, when you're kind of like playing that game of up and down and the microcatheter can seesaw with inside the aneurysm sometimes.
Sure.
It's a little cumbersome. So if you can get good, you get comfortable with anticoagulating these patients, they actually have really good outcomes.
In a stent-assisted coiling, in a ruptured, I guess a lot of times I see my partners debating, like a lot of times they'll avoid it because, when do you do antiplatelets? When do you do all this? What's your antiplatelet / anticoagulation regimen then in a rupture?
Yeah, in a rupture, it's kind of like we wait till we're like everything's all queued up. And then we do give aggrostat. We have a protocol for giving aggrostat. We'll do the case. Generally, we'll also give some heparin too. And then at the end of the case, we'll load the patient with aspirin and Plavix and send them upstairs with a maintenance rate agrostat drip for about 6 hours and then turn that off. That's a way so we know for sure that the Plavix has kind of hit its peak.
Got it. When do you start the agrostat then?
Just like literally we're about to deploy the stent.
Yeah.
Then it's like, turn it on.
Because then you're going to go. Yeah, exactly. It's these little tiny tidbits and tips are the things that you kind of learn. It's ever changing too. There's different medicines you can give and things like that. So I'm always learning these and learning what other people are doing. Are you using other specialty devices? I mean, flow diversion is just an amazing technology. It's a talk in itself. Briefly, what is a flow diverter?
Yeah, so Pipeline was the first flow diverter. Now Stryker has theirs out and everybody's coming out with another flow diverter. Balt's got one coming and, everybody wants to get in the space. It's basically, if you think of a screen door, like a screen door, so it has much more like woven metal pieces. So more flow stays within the parent vessel and less into the actual sac of the aneurysm. Does that make sense?
Mm-hmm. Yeah. And I love the technology because, at a branch point, it will keep the branch open, but it will embolize the aneurysm. So it's a technology that's slowly kind of coming. People in the peripheral space and in the body space are kind of learning it, but there's still a lot, that I think the applications of a flow diverter out in peripheral might be very, very, very cool. What about other specialty devices? There's these Webs or Pulsar stent and Kovanichi, all these different names. Are you using all these too?
Yeah, so we have used Web before, at least in my practice I have. I think it's awesome. It's an endovascular, so it's basically trying to put a device in there without, having to put multiple coils. And I think the technology is good. It's got its place. It's a niche kind of thing right now, but it's the first iteration. You know what I mean?
Yeah.
And I think the idea is there, and I think it's going to stay. And I think the space is going to really refine the technology to where it's easier to deploy. It fits better. Recanalizations or retreatments are less. And so I think it's really an interesting device.
Nice. And what about other things? Like, I think we got the pulsar stent approved one time. I think my partners used it once. And there's a lot of these little specialty niche devices for different therapies. Is that something that you guys all have access to and may or may not use it?
The thing is that some of these niche things, it sounds good, but they're clunky to use. You know what I mean? And there's this big learning curve. And when, like we said, when you're in the brain and there's a learning curve, most operators don't want to use it. You know what I mean?
Yeah.
Something like the web, they're willing to, because you can see that's a potentially disruptive technology. So we want to get our hands on it. But if it's something kind of like weird where a Y stent would work, and it's just like, why? You know what I mean?
Exactly. Any other devices we didn't really touch on? I mean, I really think between stent assisting coiling, flow diversion, and just coils, I mean, you're pretty much able to treat most of the aneurysms now via an endo approach.
The awesome thing about neuro, at least neurointerventional, neuroendovascular, is that it's one of the few spaces in medicine where it's truly an art on how you treat it. So we could spend hours talking and picking my brain or whatever, how I do it, how my partners do it. And then you go to Denver or New York City or San Francisco and they do things different. And that's what makes this space so freaking awesome, because we have the ability. It's not like cardiology where it's A, B, C, and D. And that's what makes this fun. You know what I mean?
Totally. I've gone to like Neuro Embo Club out here in LA, and they'll just start talking. I mean, there's very smart people. And there's just so many ways and so many strategic, very cerebral ways to treat.
Yeah. And that's what makes it fun, man. That's what makes this space really, really, go to work and you have a challenging case and you do well. And it's just a really great benefit for the patient. You feel like you accomplished something for them, and it's awesome.
I agree. And I think it applies to endo in general, where there's so many ways to treat. So I think that's what makes our job really, really fun, that we love doing. Whether I revasc a leg, a way how I can do this or that. It's nice than just a mundane, okay, this is how I do a knee replacement every day. I use a grit. This is really kind of, there's so much space and variety that makes endovascular treatment so much fun. What about follow-up? What's your general follow-up regimen for these patients? Is it CTA, MRA, and what interval?
So yeah, that's another little art in itself. I think everybody has their own kind of thing. Generally, I like to do especially if I put a stent, a 6-month angiogram, I get a much better look at the lumen of the stent, if there's any subtle recanalization or anything like that. If everything looks awesome at 6 months, everything's healed, I'll go to MRA. That's kind of my thing. I know for flow diversion, some people just go straight to the CTA, which is fine. I mean, if you're comfortable with that, I just, I really like to get a good look of how the flow dynamics are. And I think, doing a 6-month angiogram, like if it looks awesome, then you can just throw them to MR and you don't have to mess with contrast and all that stuff.
Totally. Yeah, I would say my guys do a 6-month follow-up cerebral angio. Frequently they use this word compaction. What does compaction mean?
Yeah, so that's like, we hate that because that's when the coils, the endosaccular device kind of pushes into the dome. So now your neck is much bigger. So it's basically a recurrence, and it kind of depends on how much compaction there is. If there's just like a millimeter of it, it's like, okay, whatever, we'll just watch it. But if it's several millimeters or it's got a funny filling along the sidewall, the aneurysm or something, then, we got to bring them back and treat it.
How often are you combining techniques now? Like I'll see my guys do sometimes, say it's a tough rupture or something, they'll coil the dome of the aneurysm and bring them back in later and then maybe put a flow diverter in or some kind of combination of that. Are you doing that often or, doing it at all?
We do it. The more comfortable I get with doing the stent assisted coiling, or sometimes we even do flow diversion with coiling, but it does happen. There's some complex aneurysms. Sometimes they're really wide neck, and like you don't want to get a lot of coils close to the parent vessel because that increases the risk of clot getting in there. So we want to, a lot of times we'll just temporize, like you said. We'll coil it really well. The rupture site, we feel it's secured. And then before they discharge, usually we'll put in a flow diverter. After everything's cooled off, they're out of the vasospasm window, and then we'll bring them back before they go home and get them queued up. It's unusual, like that. Those cases are kind of like that's not the norm.
Yeah, exactly. Now, as far as training, different pathways, what are different pathways to get to where you are, where you can treat aneurysms? We mentioned obviously radiology and neuro-IR. What are some other pathways that people might find themselves doing endovascular treatment? What is an endovascular neurosurgeon, et cetera?
Yeah, so endovascular neurosurgeon, they go through the full neurosurgery training, and they generally have an interest in vascular neurosurgery. They just love it. And, it adds a tool to their kind of armamentarium, you know what I mean? And so most of the time, they do their 7 years of training. It's generally 7. And then another year, sometimes 2 of endovascular training, and they're ready to go. So it could take them anywhere from 7 to 9 years sometimes.
Wow. Yeah.
So it's, for radiologists, like just to throw it out there, you go through the full residency for radiology, which is 5. You go through a diagnostic neuroradiology program for a year, 6, and then 1 or 2 more years for the endovascular training. So that's 7 to 8. And then, the neurology route, they generally do, I think it's 4 years for neurology. And then they go through like either neurocritical care or neurovascular or maybe a stroke fellowship. And then they go into the neuroendovascular training. So you got to bank on at least 7 years to become a neurointerventionalist.
And what are your thoughts about in the IR and the radiology space doing dual training, body IR and neuro IR?
I think it's fine. As long as you're getting enough cases and you want to just do both, I think that's fine. I think there's definitely a demand for it, as we have a guy that does that. And actually our more senior partners, they do both body and NIR as well. I think it's becoming less common because there's so much clinical and so much stuff to know in both. So you kind of gravitate towards one or the other. But if you like both, do both.
Yeah. No, it's cool. I see a couple, people who are dual trained, and I think it's a really cool kind of path if that's what's for them. Sometimes I wish I did dual training in the past, because I get so much exposure to neuro IR and I get to treat ischemic stroke, but the hemorrhagic, other than vasospasm and diagnostic, I am not treating those elective aneurysms. And, for our listeners, for, young trainees, any other kind of tips or words of advice?
Yeah. So for our radiology colleagues, first, you got to like neuro. If you like treating prostates or livers or kidney tumors and stuff, go in the body. But if you love neuro, and you got to love patients, you have to love that in the sense like direct patient care, because you're more like a traditional physician in this sense. To thrive in this space, you have to have a clinic. You have to be clinically present on the rounds. You have to go to the meetings. So technically, I'm definitely not a surgeon, but you have to have that surgeon mentality.
Sure.
You can't hide from your complications. So you have to have that kind of mindset, that kind of drive. You can't have that mindset of, I did the procedure, now it's your issue. You have to take some ownership and some participation and enjoy that. Like if you enjoy that part of medicine, it's an awesome field. It's constantly innovating, and we're always breaking ground, I feel like, every couple of years.
Yeah. Well, Aaron, that's really good. Look, it's a big topic. I kind of wanted to get into the basics and just touch on this. This is like chapter 1 of many as far as cerebral aneurysms. But thanks so much. I really, enjoyed learning from your perspective. And it sounds like your practice is booming and you guys are doing really cool stuff. So thanks for coming on. Thanks for educating our listeners. And let's talk about more aneurysms in the future.
Thanks for having me. I look forward to it.
Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabeen Dhand,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson
and Delaney Aguilar.
Social media and PR by Ann Dang.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.